Good afternoon, everyone. Hi, I hope you're well. Sorry for the slight delay there. I had a bit of a technical issue. Thank you for coming today. My name is Nikki Kinloch. I am the CEO of Cure Cancer, and it's our third Lunch and Learn session of the year with Dr. Lochlan Fennell, who's based at Monash University in Melbourne. This session will last about 45 minutes, and if you do have any questions, please type them into the chat box, and I will weave those into the conversation as we go along. So bowel cancer, unfortunately, ranks amongst the most common cancers in Australia, particularly affecting individuals over 40 years of age. The risk increases significantly with age, with the likelihood of developing bowel cancer at 50 being 10 times higher than developing it at the age of 20. Despite widespread screening efforts, preventing bowel cancer remains a significant medical challenge. So today we have Dr. Lochlan Fennell, a laboratory head at the Monash Biomedicine Discovery Institute, and he is focusing on cellular reprogramming technology to reverse cell aging. His research aims to explore whether this approach can prevent gene mutations associated with cancer by rejuvenating the cells. This Cure Cancer funded project could be led to personalised treatment and prevention strategies tailored for older patients at greater risk of getting bowel cancer. So first of all, welcome, Lochlan.
Thanks, Nikki. How are you?
Good, thank you. I'm particularly interested in anti-aging cells for many reasons, but but before we get talk about the use of them for bowel cancer, could you just give the audience, for those that haven't met you before, a little bit of an introduction about you and how you got into research?
Yeah, absolutely. So as Nikki mentioned, I'm a laboratory head at the Monash Biomedicine Discovery Institute, and my lab really tries to understand the role of aging in cancers more broadly, but in particular in colorectal cancer. So I got into research about 7 or 8 years ago. So I did a biomedical science undergraduate degree, and then I did a PhD in colorectal cancer up at QIMR Berghofer in Brisbane. And that's when I started really getting interested in the aging process. So in that PhD, we were really particularly interested in why a certain type of bowel cancer only tends to arise in people that are above the age of 70, for instance. But we know that the polyp, so that lesion that ultimately leads to bowel cancer, was found in a wide spectrum of patients regardless of their age. So in that project, we made a critical discovery that even though that polyp, which looks identical down a microscope, down the colonoscopy, even though you've got the same polyp, we found that if that polyp tends to occur in an elderly patient, it's at a much, much higher risk. And we started exploring how this might be occurring. So what is happening in aging? So we linked it to a number of different mechanisms. And the important thing here is that if we can really drill down on what goes on with aging, we've got a really nice window of opportunity to try and address it. So if bowel cancer tends to occur in patients aged 50, 60, 70, that means we've got a 50-year period to which we can identify those at risk and then ultimately try and target them for either precision screening or more preferably try and develop a treatment strategy so they never go on to develop bowel cancer in the first place. So that's a bit about sort of where I've come from and where I am today. And I'm really excited to talk about some of the research that we're doing that's funded by Cure Cancer.
Yeah, look, it's great to have you here, so thank you. We've touched on this before in the past with other Lunch and Learns. Now, often some cancers are degenerative, which means the older you get, unfortunately, the more likelihood you get that type of cancer. And obviously that's the same as bowel cancer. Could you, in lay terms, as much as possible, talk a bit about what you know about why an aging cell would cause you to be more likely to have cancer?
Yeah, and I think there's a whole heap of different things that are going on throughout the aging process. So aging broadly at that sort of cellular level really describes a decay of normal processes. So the normal things that keep a cell in check. So as a normal cell will age, you tend to get more of these gene mutations occurring. So they just happen sort of randomly as you age, and the processes that are in place to sort of repair them tend to start decaying as well. So they are maintained throughout the aging process. You've also got the immune system, which tends to start to decline with age, and a whole heap of different processes that are going on that sort of converge towards having an increased risk of cancer. We also think that as you age, that cell that gives rise to the cancer, which previously was a normal cell, it was just doing its job, we tend to think that it becomes less competitive. So compared to all the cells around it, it's at a competitive disadvantage. So if there is something that can give it a leg up, such as a mutation in one of these really important driver genes that cause cancer, it will take that and it'll form those early lesions that go on to form cancer. So we think that there's a whole heap of processes that converge to make a cell that is not really fit for purpose anymore. And when it has the option to get one of these mutations that are so critical for cancer, it takes that option and off the cancer goes.
Okay, that makes sense. Thank you. For those that aren't familiar with bowel cancer or bowel cancer screening, in your introduction, you talked about polyps. So do you mind explaining a bit about them and why they're so important?
Yeah, so bowel cancer is a quite unique cancer in that it's got a stage between being a normal cell and cancer, and we call these polyps. And what they are these sort of benign, sort of normal, not normal, but these non-cancerous growths that occur in the bowel. And most of these polyps, these growths, will eventually transition into cancer. The thing about these polyps are we know a little bit about how long it will take for them to develop into cancer. And we also have excellent methods of removing them and thereby preventing cancer from ever occurring in the first place. So that's why we have the bowel cancer screening, which will detect whether a patient may have bowel cancer. And that's why we have colonoscopies. So that's where we go, where the endoscopist will go in with a camera and they'll identify these growths in the bowel that could cause cancer and they'll remove them. And that effectively cures the patient. And it's this unique sort of spectrum of disease that allows us to get in really early and allows us to prevent a lot of cancers. And it really has been a public health achievement in Australia over the past 15 years that we've been able to identify these precancerous polyps, remove them, and prevent so many cancers. And even if we do identify cancer, we tend to identify them earlier. And that is so critical. If we can identify cancers earlier, before they spread to other organs, we have a very high cure rate compared to when it's already spread to distant organs.
And I think, to your point, and with a screening program, it's so important that the message here would be when you get to that age that you qualify for that program, you should absolutely take part in it as well.
Yeah, absolutely. And I think there is changes afoot in that screening program. So one of the unfortunate things that's occurred over the past 2 decades is we're starting to see some of these cancers occurring a little bit earlier. So while I mentioned that this is usually a disease of the elderly, we are seeing younger patients who wouldn't usually have bowel cancer starting to get bowel cancer. And there is movement afoot to move that screening guideline to 45 in line with a few other nations around the world, the US being a major one. And that will address that rising concern that we are seeing cancers earlier in younger patients. But again, one of the big problems with this screening is it's not perfect. And a lot of patients will have a positive test but won't have cancer. So we can't roll this test out to the entire population because there's more and more false positives and more stress for those patients that don't have cancer if we start giving it to every patient across the nation.
Thank you. So let's just go back to your screening, and you've been screened and they find that you have a polyp. Can we talk about the link between the clinicians and you as a researcher? When do you get involved and how do you get involved?
Yeah, so that's a really good point. So me being involved in the sort of aging process, I like to get involved as early as possible. So we do a lot of our work on normal tissue because we want to understand what goes on in the normal setting of aging. So we collaborate very closely with the gastroenterologists and the surgeons who actually go in with the colonoscopy. And we actually get biopsy specimens. So that's where they take little pieces of either the normal bowel or the polyps. And we're able then to go take them back into the laboratory and do various tests with them. We're able to grow these really innovative sort of 3D models. And these organoid models, these 3D models, they really recapitulate what's going on in the bowel, and they're incredibly powerful model systems. And we couple this with a lot of genetic methods that we can use to really understand what's going on with aging and why cancer might develop. So we try and get involved as early as possible. We also work with surgeons to get involved once cancer's already occurred, so we can try and understand bowel cancer more broadly as well.
Interesting, thank you. And we've talked about organoids in other types of cancer, and they're just really incredible that you can actually grow these cells outside of the human body for a period. I think when we talked about uterine cancer, it was for 2 weeks. And you can test and learn on them outside of the body, so you're not actually testing on the patient themselves as well, which is incredible.
Yeah, absolutely.
So moving on, so you talked about discovering the link between aging and cancer, particularly for bowel cancer. So let's talk a bit more about your research. I mean, how did you do that? What caused that discovery? How did you get that? And then what are you looking to do now with your funding from Cure Cancer this year?
Yeah, so I guess that discovery is based on sort of epidemiological public health-like evidence that we've known for a very long time, that the risk really does start to rapidly increase after age 40, age 50. And that's where we base the screening guidelines around. The particular discovery that we made was that for some reason, this particular type of polyp, a particular subtype of polyp, can occur in someone as young as 20, but the cancers that occur from that, and we can use different genetic methods to work out how that cancer's occurred, really only occur in the elderly population. So to sort of tease this apart more, we used a couple of model systems where we would pick the driver mutation, so the event that causes this polyp to occur in the first place, and we put that in the model from a young person, and we just monitored over time. And if you do this, you do see cancer develop, but it takes an extremely long time to develop. When we did the exact same experiment, but instead used a model from an age setting, we saw that cancer developed really rapidly. So it was about a 10 to 15-fold decrease in the time taken for cancer to develop, driven by this particular mutation. So that's where we got really interested in what's going on here in the aging process. And one of the things that really intrigued us, and there was a study out a few years ago that showed that you can actually genetically manipulate these cells, these elderly cells, these aged cells. You can rejuvenate them genetically and make them recapitulate what that young cell looks like. So that made us think, if we can do that, what happens if we attempt to do that? Does that make those now rejuvenated younger cells resistant to cancer? And if it does, that's a game changer. If we can make those cells youthful again and they don't form cancers, that is sort of the holy grail of prevention. We can stop cancer from developing. And so that's the project that Cure Cancer is going to be funding. We're going to be exploring whether we can actually do this and whether those cells now are unable to form cancer.
Thank you. I'm just going to pause there for some new people that have joined us. I'd like to welcome you to our Lunch and Learn, the third of this year, with Dr. Lochlan Fennell, and we're talking about his work that Cure Cancer funding this year on bowel cancer. So when you talk about rejuvenating, you're actually taking the existing age cell and almost turning back the clock. Is that right?
Yeah. So essentially, we're taking those existing age cells, changing some of their genetic makeup, and like you said, turning back the clock. So when we do this without thinking about cancer at all, they start to behave a lot like young cells. They regain their ability to regenerate. They regain a lot of their functions that we expect from those normal cells that line the bowel, and they're just healthier cells. So that's why we think that these cells might be more resistant to cancer forming in the first place. So yeah, we take those cells from the age setting and we try and turn back the clock.
I mean, that's fascinating, because when you think about it, it could work for all different types of cancers, not just bowel cancer, if you're successful as well.
Absolutely.
Lovely. We've got a couple of questions. One is a very scientific question. So bear with me as I read my way through this. But can you speculate what would happen to the microenvironment, specifically the microbiota on epithelium upon reprogramming of the cells?
Yeah, and this is a really interesting point and something we've given a little bit of thought to. So We know that the microbiota, so that's
Maybe,
talking about
Lochlan,
those.
I was going to say, Lochlan, maybe you could just explain what that means
Yeah,
for the lay audience first.
yeah. So the microbiota is really referring to those bugs, those bacteria that you find within your bowel. And a lot of research has gone on over the past 10 years, 15 years that shows that the makeup of those bacteria that are in your bowel is actually really important for a whole host of different disease processes and important for health in and of itself. And a number of different things can influence this. So we know that diet can influence the makeup of that microbiota or that bacteria. We know that antibiotics, probiotics, all these things can influence how that microbiome, microbiota, all those bacteria actually form within your bowel. We also know that it's really important for bowel cancer. So we know that a patient who has bowel cancer has a very different set of bugs to a patient who doesn't have bowel cancer. So there's something going on here, and that's actually an active area of my research as well, understanding how they contribute to cancer developing. In terms of how reprogramming these cells might affect that microbiota, I guess that's an open question, and we're not quite sure. One of the things that's important to note is that the microbiota of younger people tends to be a little bit different to that of elderly people. So one could speculate that by turning back the clock, you might actually alter those bugs as well, because we know that they talk to the cells that we have in our bowel, also talk to the bacteria and vice versa.
It's really interesting because we 2 years ago we had Dr. Marlene Howe, and she based in Melbourne was looking at the link between your bowel and what's in your bowel and your stomach and brain cancer, with the theory that actually everything is driven from your bowel, including the microbiomes. And there was a link between brain cancer and what was going on in your bowel. So it's fascinating to hear, even 2 years later, you're talking about this as well, and the importance of it. Good gut health is important.
Absolutely, certainly is.
Another question we have here from Hannah, and she's asked, as Australia's third most common cancer, do you believe, and we've touched on this a bit before, do you believe that the free bowel cancer test kit should be available to everyone, or just to people that have had a family history of it previously?
Yeah, and I think this is something that the field is still grappling with a little bit. There's a few things that are going on with bowel cancer screening, especially in Australia, being a sort of single payer universal healthcare system with only a limited amount of resources. So I think the first thing is that we know that bowel cancer testing kit that gets sent out is really good at detecting cancer, but it has a lot of false positives as well. So you can have a positive test on that kit that comes out. You can go in for a colonoscopy, which is usually what happens. So if you have a positive result from the free test kit, you'll end up going to a surgeon or a gastroenterologist who will go take one of those cameras and have a look around and see if they can identify anything. But we know that there's so many other things that can cause a positive result on that initial screening test. And that becomes problematic if you roll it out across a whole population. So we also know that false positives increase the younger and younger we give these tests to. So if you give these tests to all 20-year-olds, there'll be a lot of false positives. And that creates distress for the patient, but it also adds an enormous stress on the finite resources we have in colonoscopy. So if we refer these patients who are at notionally low risk for a colonoscopy, we have to redistribute resources a bit and potentially take away colonoscopy from someone who's a little bit older at higher risk, or they'll have a longer waiting period. So it is this balancing game between not over screening, but also screening the people that we really need to. And I think that goes to the second point. So family history in bowel cancer is very important. And the current guidelines do take this into account. So if you have first-degree relatives, if you have multiple first-degree relatives, the recommendation is that screening using that free test kit does start earlier. And this is just to address the fact that you're at a higher risk of developing bowel cancer. So I think that there's definitely work to be done in tweaking around the edges here. But I think we're incredibly fortunate, at least within Australia, to have access to this nationwide screening program from hopefully 45, if that ends up being approved, because it is something that has definitely driven down the incidence of bowel cancer within Australia. But hopefully moving forward, we can be a little bit more precise in how we actually do those tests. And I imagine that over the next 5 or 10 years, we'll have better and better tests, potentially less invasive tests that allow for the detection of bowel cancer.
Thank you. It's a very good point. Another question, noting you are not a clinician, so you can answer the best you can, but
Yeah.
a question about preventative measures. So
Mm.
obviously we just talked about good gut health. One of the questions is, as you age, what should you be doing more of to limit your chances of potentially getting bowel cancer?
So I guess there's more of and there's less of.
Mhm.
So we know that there's some really strong risk factors for bowel cancer. So smoking, even though you think conceptually the cigarette smoke goes into your lungs, it actually affects all your organ systems. And smoking is one of the strongest risk factors for developing bowel cancer. So stopping smoking is obviously one of the key things. Exercise and physical activity. So a number of different studies have shown that highly active people are less likely to develop bowel cancer. And the third one is probably diet. So patients who are obese, patients who have high fat diets are more likely to develop bowel cancer. All these things together contribute to your risk, but we do also know that there is an element of randomness. We can't predict who's going to develop bowel cancer. You can have all the screening, all the risk factors in the world and never develop bowel cancer, but you could also have no risk factors, and we see this a lot with our younger patients. You can also have no risk factors and unfortunately develop bowel cancer. And again, this is a really active area of research in sort of precision prevention, but also risk stratification. So working out who is most at risk of actually going on to develop bowel cancer. And I hope that we make some progress on this over the coming years.
Yeah, lovely. Thank you. To the audience, if you do have any other questions, just drop them into that chat box. Happy to feed them in. So what's your day in the lab look like? For those that don't know or have never been in a lab, explain what your typical day looks like, if there's such a thing.
Yeah, so a typical day. So we do a lot of work with those 3D models that I was talking about, those organoid models. So a typical day might look like sort of liaising with our colleagues in the Department of Surgery and Gastroenterology to obtain these samples, and then getting into the lab and actually processing them. So there's quite a bit of work that goes in between sort of getting the sample out of a dish from the surgeon or gastroenterologist into turning it into one of those really innovative, cool 3D models. So we do a lot of that work, and we do a lot of banking of that too. So we are incredibly lucky and grateful to have patients who participate in our studies. And a lot of the work we do is building up a really nice resource of diverse organoids that we can use for various projects. So I'm talking organoids from patients who are young, who have no underlying disease, organoids from the cancers themselves, organoids from aged patients, a whole heap of different things, so that we do have the ability and capacity within our lab to go and test various approaches, with cellular reprogramming being one. When we actually get in to do the lab work, unfortunately, one of the things that we spend a lot of time doing is sitting around this really large flow cabinet hood thing, which is hard to describe, but just imagine that you've got this buzzing noise for 4 or 5 hours a day. And we're just really manipulating those organoid models. So we might introduce a specific genetic factor to them, and then we do tests throughout that coming week to work out whether that's actually altered their behavior in any way. The other thing that we do quite a bit of is computational analysis. So this is where we've gotten to the end of an experiment, and now we've got this really rich data. And I'm talking data that is unfathomable to think about how large it is. So we need a way of processing that. So we also spend quite a bit of time working with computers and using sort of a big data approach to try and identify how our manipulation has affected that organoid, and also to understand how the cancers are developing in the first place.
And from a team perspective, can you just explain a bit about who those people are in the team and what roles they do?
Yeah, so I'm incredibly fortunate to be supported by a number of people within my group. So I've got a very talented PhD student. So a PhD is a sort of a research apprenticeship type thing. So this is where you come in, you do a 3 or 4 year degree, and your aim is to contribute something new to the body of knowledge. So I'm really lucky that this project is actually being driven by one of my current PhD students, and he's doing really well. He started about 12 months ago, and he's making great progress on our age-related projects. I've also got a number of research assistants, and their role is really to support the experiments that are going on in the lab, and they really are sort of the driving force behind what goes on. So they'll be the ones doing the experiments from day to day, making sure that we all have the support within the group to individually succeed. So it really is a real team effort, and that extends beyond just in my laboratory. Our research is incredibly collaborative, so we work very closely with a number of different research groups within Monash and also externally. We work very closely with clinicians, and obviously we work very closely with patients from the perspective of obviously obtaining their consent to participate in our studies, but also working with them to co-design some projects, which I think is just so valuable. Getting that lived experience of cancer really informs what we do. And I think having their input is also valuable and makes them a really valuable member of our team. So I guess what I just want to emphasize that it really is a team effort. There's no one person working in a silo that's getting any of these studies done. And I think that's really important.
Absolutely, thank you. And let's go back to the reprogramming or the turning back of time of these cells. Have you seen any research from other projects or internationally where they've done some of this reprogramming as well, and you've used that work to help you in your current research for bowel cancer?
Yeah, so I guess we've based this study, and it will be the first study that attempts to look at it from a cancer point of view, but we've based this on a whole body of literature that really goes back more than a decade ago to a Nobel Prize winning discovery that you can actually change what a cell's identity by changing certain genetic factors. So you can turn a muscle cell into a brain cell, for example, just by manipulating certain genetic factors. And that's this whole idea of reprogramming. So it's taking a cell of one type and turning it into a completely different type. And that's really formed the basis of this field, and it's really forming the basis of all of regenerative medicine. So if you think about how you generate organs and things like that, it really is manipulating certain genetic factors to provide for that to occur. There's been more recent discoveries in terms of the aging field. So a few years ago, one of my colleagues at Monash actually identified a number of different genetic factors that will turn back time or turn back the clock. And they're the factors that we're initially focusing on. But we're not sort of having tunnel vision in this respect. So we're also trying to explore other factors, other genetic factors that might also aid in that process. Probably one of the more exciting things that's actually developed recently is the idea of chemical reprogramming. So what we've been doing so far is manipulating genetic factors. Now, that's actually quite difficult to do, especially even within a laboratory setting. So if you take that discovery into a clinic, there's a really large gap between sort of doing that in a lab in a dish and doing that safely in a patient. Chemical reprogramming is this idea that there's certain drugs or chemicals that you can give to someone that will do the exact same job, that it will turn a cell from one type to another type. And I think this is incredibly exciting because if we can identify a certain drug that can do the exact same thing that we're trying to do from a genetic point of view, all of that wide gap between where we are now in the clinic suddenly becomes a lot more narrow. So they're the sort of things that we're thinking about, and that's been informing our research.
It is. It really is exciting. I'm just thinking as you're talking about what else you could do with the, you know, from not just cancer but other diseases as well, if we can reprogram those cells. What would you say is your biggest challenge on a day-to-day basis in the lab?
There's a few. So I guess our biggest challenge probably relates to access to resources and funding. And I think this is where charities like Cure Cancer are so pivotal in supporting research. So the funding environment around the world is quite harsh, and only about 10 to 15% of the proposals that get submitted for government funding actually get funded. And governments tend to shy away from high risk, high reward research, which in my view is the research that's really going to push those frontiers. So access to resources and grant funding through smaller charities, through philanthropic means, really gives us a leg up, especially as an earlier career researcher, where we might not have access to traditional funding sources. So I think that's probably the biggest pinch point in research. If we had unlimited time and unlimited money, we could do a lot more, but unfortunately that's not the case.
Yeah, it's always the problem, isn't it? I mean, that's the very reason we've existed for 57 years. And, you know, it would be great if the job was done and we wouldn't have to be here. But it's an ongoing challenge, and making sure that innovation is funded and new ways of thinking, just as you guys are doing, which is incredible work. So wrapping up the research piece, what are your hopes for the future? Where do you think this work will take you?
Yeah, I guess broadly, and if we're thinking long term, my hope is that bowel cancer doesn't happen. So a lot of research is focusing in treating bowel cancer, different modalities there. By focusing my research program on prevention and risk identification, the real goal in the end would be to identify people who are at risk and screen them intensely to make sure they don't develop cancer, or develop a nice preventative therapy so that we can stop this disease from ever occurring. Because I think that's where we're really going to make inroads over the next 20, 30, 40 years. It's going to be prevention rather than cure. And I do think that prevention is always better than the cure. And if we think back to a number of different sort of public health initiatives that have led to this, so the identification that smoking is the biggest risk factor for lung cancer has precipitously decreased the rates of lung cancer, which is a win. UV and melanoma, sunscreen, all these things that prevent cancer have saved so many lives. And I think that my hope is that my research can contribute in some way to preventing and identifying those at risk for cancer.
Yeah, look, you're absolutely spot on. I mean, if you look at Gardasil being developed in Brisbane by Professor Ian Fraser and his Chinese counterpart, and that is seeing the elimination of cervical cancer, and it's just incredible to think that you know, that is happening now globally, and I believe by 2030 they think there will be no more cervical cancer in Australia, which is incredible. And if only we could do exactly the same thing with bowel cancer as well. Before we wrap up, and thank you for sharing your work with us, do you have any last messages for the audience here today?
I'd just like to end by thanking, obviously, everyone for coming along today and listening to our research, but also to thank any of the donors that contribute to cure cancer. The contribution that you make is just so invaluable to the work we do, and we couldn't do this work without having access to those resources. I'd also like to thank all of the patients who make our research possible. So patients that are going through the worst times in their life are contributing to our research for the betterment, usually of other people. And I think that is just an incredible thing to do. So just like to end by thanking those groups.
Look, absolutely. I think there's two messages here. It's, if you qualify for the screening program, absolutely take part. And then when you're asked if you want your cells to go off for clinical research, I think the answer would be yes, wouldn't it? So look, Lochlan, thank you for sharing your work. It is incredible what you're doing. I look forward to hearing your progress, and I know everyone else does as well, because as we said, not only wouldn't it be a great world if there's no more bowel cancer, but the impact across other cancers as well in the future could be incredible. So thank you on behalf of the whole audience and our donor base for your hard work too. Well, thank you guys for everyone that's joined us today. I hope you enjoyed that. If you do have any other questions for Lochlan, please drop us an email at info@curecancer.com.au and we'll pass those on to Lochlan. The next session we'll be having is on the 2nd of May, our lunch and learn at the same time, 12:30. We'll be talking to Dr. Taskeen Janjua. She's at the University of Queensland, where we'll be discussing her pioneering work on the very sadly deadly glioblastoma. That's a form of brain cancer. So please join me then. But until then, thank you for taking part in this session. Thank you to Lochlan, and we'll see you on the 2nd of May.